Good evening, everybody. Welcome to this session of 52nd Comprehensive Course on Echocardiography. I'm Dr. Rakesh Gupta from Jorap Institute of Echo. Today, we are going to deal with Doppler and color flow mapping, their basic principles. This is the third session of this particular program. As you know, we are in this teaching program for more than 25 years. And this is the auditorium where you're likely to have your hands-on training program when you come back for hands-on programs. Many people who are behind this program is none other than Dr. SK Parashar, who is right now taking your class. Apart from that, we have Dr. Naveen Sinanda from USA, Dr. SK Chopra from Mulchand Medicity, Dr. Sanish Srivastava from Saket Max Hospital, and apart from that, Dr. Hansa Gupta, she works in Paras Hospital in Gurgaon. Two people you have been communicating. One of them would be Rina Dua, number of times. And second, when you come for hands-on, we'll have Dr. Narang taking care of your hospitality. We have many accreditations. We have accreditations from Indian Academy of Echo, International Society of Cardiovascular Ultrasound, Alabama, USA, Delhi Medical Council. And whenever we do a hands-on training program, we take up permissions from appropriate authority for hands-on training sessions. We have a recognitions from Parul University for conducting 1-year fellowship programs. And last year, we were instrumental in conducting echo training program for technicians with BPO. We can boast of saying that we are the only institute in India talking of hands-on sessions. We started in April 2000, and we already completed more than 25 years of our training. More than 5,000 people have attended this program, and we celebrated 25 years on 17th August 2025. Couple of photographs with all people who are responsible behind these training programs. This was named as Cardio Convergence. And today is third session of this 52nd comprehensive course. And it's being taken by none other than Col SK Parashar, who is the past president of Cardiological Society of India, the founder of Indian Academy of Echocardiography. He has been bestowed in many Lifetime Achievement Awards. The main important one is the Lifetime Achievement Award by former President of India, Dr. APJ Abdul Kalam. He has published a book of Indian Academy of Echo, and he's one of the co-authors for this particular program. Sir, with these few words, it's all yours, Doppler and color flow mapping. And I'm going to stop sharing my slides so that you can share your slides, sir.
Okay. Where have we gone? Can you see the slides?
Not yet, sir. We have to share, sir.
Not
I
yet.
request everybody to switch off their videos, because then we'll have a better perfect.
Not yet.
Not yet, sir.
I'll come back to
Sir,
because this I have to remove first. I don't know how it has come. Now I think it should be there now.
yes, sir. It has started showing, sir. Double click to enter full screen.
Yeah.
Perfect, sir. You can click the wine bottle sign. It will become bigger in size.
No, I've already, I think this is the bigger one also.
Perfect, sir. It's a perfect, sir.
Good. So before I go to the talk proper, I have some sort of a blunt comments for the participants based upon our experience. I told you the first day that the first 2 lectures are extremely important for your course, and they are the sort of a foundation of the course. I don't know how many of you have repeatedly read the first lecture which was given by Dr. Gupta. So because every lecture is sort of a interconnected, then whether you accept it or not, I know that majority of you have never opened a book in the last several years. So you have not opened the book for last several years. So this is something new for you. and you have to change your habit. If you want to take the maximum benefit of the course, please read, not even now, but in future also. So that will be the basic for this. Now, in our lecture, you can always interrupt in between rather than waiting for your clarification in the end. So that the whole sequence is missed, you can interrupt anytime during the talk if some clarification is not there. And again, I would request you that this is an important chapter and you must read it daily or so. And I will go very slow because although the talk will be for about 20 minutes in lecture, but I will take about 35 to 40 minutes to make it very, very simple and never be worried about what is Doppler. It will be very easy for you after this talk. Now, why I brought this slide is that it is of the name. We still see many reports where doctor is written with a small d. It is the name of the person concerned, and he is responsible for all the development which we have done today. So this will the person who inverted the Doppler, and that is why we always write with a capital D. Now, what are the mantras of echocardiography? Some of them you will feel important later on, not today. You must have a good clinical assessment. I will show you one or two cases, not today. If we had a patient who was being treated for dilated cardiomyopathy, and when nobody tried to put a stethoscope on her, she was about 50 years of age. And when she came to us, either by mistake or by habit, we put a stethoscope and she was found to be a case of patent ductus arteriosus, a treatable condition from a non-treatable one. You and patient should be fully comfortable. Never do an echo without an ECG. So because you require many things in the ECG, for example, you see here, now the physician orders an echo to be done. Nobody bothers what. Now see here the patient has got a 2 to 1 AV block with a heart rate of 35. Now, if we had not attached the echo, the ECG, we would have missed this diagnosis and we did a rapid echo and we sent the patient to the ward. Again, you see another patient, heart rate of almost about 120. And when you start doing an echo, you'll find that any heart rate more than 100 or so produces a bit of a problem in the echo. So if today this patient comes to me with heart rate 120, I will possibly delay the echo till the heart rate is controlled. So number one, it looks after the rate, rhythm, and the cardiac cycle. This will come to you later on. This you will be clear after the today's talk that in every echo we start with a 2D echo, then go to the color flow and then to a Doppler. Why? This will be more clear to you today. So at this slide is that have a good see the ECG, see the X-ray, auscultate the patient, put an ECG. There's no excuse that ECG was not available and all these things or so. Now, the views have been told to you. There are many views, but you are mostly concerned with a left parasternal view, apical view, subcostal view, and suprasternal. And this you will be practicing, I think, during your hands-on training. So these views have already been told to you. So you have three things to see. Whenever you do an echo, you have a clinical information, anatomic information, and hemodynamic. And anatomic information is by 2D echo. That is what has been told to you, what is the size of the chambers, what are the thickness of the chambers, any anatomical of any walls to be seen, or any anatomical information is seen by a 2D echo. And a hemodynamic, that is hemo means blood and dynamic means flow. So this Doppler is the backbone of cardiology. So this, remember the 2D echo will usually give you a semi-quantitative idea. What is the semi-quantitative severity, but the true severity is given by the Doppler. So these two are extremely important and go stepwise and never be in a hurry. Again, I told you, any problem, please do go on interrupting in between. Now, this diagram, you should, believe me, practice daily. This is the basic hemodynamics you studied in first year MBBS, completely ignored it and forgot it. And if we would have been having a live cases, I would have told you how many of them you don't know or so. So remember, this is the backbone of your daily studies or so. The blue is the venous flow. As you know, the blood from the superior vena cava, that is from the head and neck, and inferior vena cava, they come into the right atrium. This is the most basic slide. If it looks too simple for you, don't worry, but it will be a practice daily. So the inferior vena cava, superior vena cava, blood goes into the right atrium. From the right atrium through the tricuspid wall, it goes to the right ventricle. Now, these are known as this is also known as the atrioventricular walls. Atrioventricular means they are between the atrium and the ventricle. And these atrioventricular walls, they open in diastole and close in systole. So when the blood from the RA goes into the RV through the tricuspid wall, from the RV it goes to the pulmonary artery. Now these are known as the ventriculo-arterial walls. That means they are between the ventricle and the arteries. There are two main arteries, pulmonary artery and the aorta. So these are the ventricular arterial walls which are opposite. They open in systole and close in diastole, just opposite to the atrioventricular walls. And from the pulmonary artery, they go to the lungs where they are oxygenated. And from the pulmonary veins, they come to the left atrium. It is known to you, but it is still a revision. And from the left atrium, through the mitral valve, it goes into the left ventricle. So again, this is known as the left atrioventricular valve, or ideally the mitral valve. And it opens in diastole and goes to the LV. From there, it goes to the aortic valve, that is the ventriculo-arterial valve, into the body. So I would suggest it won't take you, believe me, more than 5 minutes or so, but you must revise it daily. So you see, here it is written mitral valve. Now here it is written aortic valve between the left ventricle and aorta. Here it is the pulmonary valve between the right ventricle and the pulmonary artery. And here it is the tricuspid valve. So remember, this is the basic anatomy and the flow. And you will see how important it is during the further thing or so. So the atrioventricular valves, that goes between the atrium and the ventricle, and they are the mitral and the tricuspid valves, they open in diastole and close in systole. The pulmonary and the aortic valve, which are between the ventricles and the arteries, the opposite, they open in systole and close in diastole. So this should be very clear to you. Believe me, many of the candidates, even right up to the 2-3 days of the course, never understood what is diastole and systole. So I think this should be very clear to you, which I've gone into very slowly. Again, please read this diagram and see what does it say and how does it happen. Now, for example, you see, this is a parasternal long axis view. The aortic valve opens in systole and the mitral valve closes in diastole. You see, in the diastole, it closes in systole. So this is just to show a static image that when the aortic valve opens, there is systole, then this closes. While in diastole, when the mitral valve opens, the aortic valve closes. So this is just to tell you, in diastole, the mitral valve opens, aortic valve closes. In systole, the mitral valve closes and the aortic valve opens. So these are the basic things which you should know by now, and it is nothing very special which we have told you. Now remember, these are, again I will tell you, don't misunderstand me. Many of them could never know even up to third or fourth day. The diastole and systole are very important. I always give a example of a balloon. No, for survival, no, what happened? In a dead patient, the heart neither fills up, neither contracts, the heart is stopped or so. So that is that means for a survival, heart must fill up and heart must eject blood. So this is the function of the heart. Otherwise, a static heart will is only found in a dead cases or so. So what I always give you an example of a balloon. When you fill up a balloon with the air of water, it expands. So that is known as diastole. Any chamber which fills up definitely will have an increase in size. This is natural thing or anything. Then when if you remove the air of water from the balloon, it decreases in size. So that is systole. So remember, both of them are extremely important for survival in every chamber of the body undergo diastole and systole. If the LA cannot fill up, then how can it fill the ventricle? If the RA does not fill up, how can it fill the right ventricle? So that every filling is in diastole. Remember, at every ejection or systole is when they decrease in size for survival. That is the important thing. So these are the two. Remember, now I don't know how to make it more clear to you that in diastole it is filling, in systole it is ejection. And both of them are very important also. Then you will be hearing the term pressure and a volume overload. Now, believe me, in this Doppler, I will not tell you any physics or so, because that will be very confusing. Again, you see the same thing. Now, you see, this is left ventricle. I keep my LV on the left side, this is right side. Now, see, this is LA, LV. Now, this tells you that the LA opens into the LV. And in diastole, the mitral wall opens and in systole closes. Again, you see on the right side, when the filling occurs of LA, it increases in size. You see, it increases in size and decreases in size. It will decrease in size when it ejects into the LV, and the same thing is RA and RV. So all the chambers increase in size and diastole, decrease in systole as the mitral wall closes. The same happens in all the four chambers. Now, again, this is static image you see. In diastole, the mitral wall opens, the LV becomes larger, LA becomes small because it has now ejected blood. In diastole, the LA fills the LV, LA becomes small. In systole, when the ventricle is in systole, the LA is in diastole, it increases in size because it is filling up from the pulmonary veins. Remember very carefully that here the ventricle is being filled up, hence it is larger in size as compared to systole, and here because the LA is ejecting blood, so it is become less in size as compared to the systole. What happens when the systole, when the chamber is in systole, LA is in diastole because it is filled up from the pulmonary vein, it increases in size. So these two slides should tell you that what is diastole and what is systole, how a chamber increases in size during diastole, reduces in size during systole, and the same apply to the atrium. Any chamber which fills up it is diastole. So here when the ventricle is contracting, LA is relaxing so that it fills up the next cycle. A ejection and filling has to continue side by side. I hope this is very clear to you. Any doubt, please go on asking to me, especially diastole and systole. Again, you see another view. This is a three-chamber view. I hope you have studied. This is the LV, this is the aorta, this is the LA. Now see, mitral wall opens in diastole. In diastole, you see the LV increases in size. It closes in systole, LA increases in size. So you go on following the LA, how it decreases in size, how it increases in size. Increase means it is being filled up from the pulmonary veins, and small means that it is filling the left ventricle, and you see the LA, LV, when it is filled up, the mitral wall is open. When it fills up, it increases in size. When the mitral wall closes in systole, it decreases in size. So again, these are diastole and systole. I have taken the maximum time for diastole and systole to explain to you. Now, then you will be hearing two words again, a pressure overload. Don't look at the slide, but just hear what I say. A pressure overload is whenever a chamber is subjected to increased pressure in contracting and filling up a chamber. For example, in the left side, suppose the patient got an aortic stenosis. So when the patient has got an aortic stenosis, there is a narrowing of the aortic wall. The left ventricle has to increase its pressure to push the blood against an increase. After load means the load after contraction. For example, hypertension, aortic stenosis, the same thing right side. Volume is overload when there is a large amount of blood in a chamber. For example, in aortic regurgitation, if you remember the anatomy, what I told you just now, left ventricle fills up both from the mitral wall LA and both from the aorta for regurgitation. So there's increased volume. So this is known as a volume overload. So pressure overload is whenever there's an increased resistance to pressure, emptying, for example, the same thing on the right side, we'll show it just now. So this is the pressure. Name indicates that a chamber has to put up an increased pressure to empty itself into the chamber. So this is the pressure overload. Commonest cause being aortic stenosis, pulmonary stenosis, hypertension, volume, when there's a large amount of blood coming in a chamber because of from two sources. Now, many of you would have forgotten by now. You see every time an ECG daily, but you forget what are the basics also. I'm telling you ECG, and I can assure you that if I ask, many of you will not able to answer or so. Now, the systole is from the QRS complex to the T wave. End of the T wave, this is known as an ECG systole. From the end of the T wave to the QRS complex, it is diastole. Remember, so till now, and the P wave is the atrial contraction. So remember, this will help you in timing your echo findings. The onset of QRS complex to the end of the T wave is systole when the heart is contracting, and from the end of the T wave to the next QRS complex is diastole. So always remember the QRS and T wave and T wave and QRS. So these are the two important waves, QRS, T and QRS. For example, just giving an example here, you see here, from the QRS complex to the end of the T wave is systole. End of the T wave to QRS is diastole. You see always the same thing here you see. From the QRS complex to the end of the T wave is systole, and from the end of the T wave to QRS complex is diastole. Always a diastole is more than the systole. So I think you should now be clear that which is systole and this which is diastole. And the same thing has been shown in this slide, that from the QRS to the end of the T wave is systole, and from the end of the T wave to the next QRS is diastole, and the P wave is atrial contraction. Now, if you remember what I told you just now, this is the mitral wall. I hope you remembered it by the last lecture. This is anterior, this is posterior. In an echo, this is always anterior, this is posterior. You see, I told you the mitral wall opens in diastole. You see here, this is the end of the T wave, and diastole starts and the mitral wall opens. And you see this closes at the systole. From the QRS complex to the T wave is systole. So even by mistake, which should not be pardoned, if you don't have an ECG, you can say that this is diastole, this is systole. Because the wall opens in diastole, it always shows an opening of the two cusps, and in systole, because it closes, it is usually at the single line because it is only as a single line you see. So again you see, this is the diastole where mitral wall opens, and this is the systole where the mitral wall closes. Now, although this is not connected with the with your lecture today, but you see, blood always flows from a high pressure chamber to the low pressure chamber. I will go very slow. Any problem, let me know. Now the LA is being filled up from the pulmonary veins. So a valve will open when a high pressure chamber will eject blood in a low pressure chamber. So in the left atrium, the pressure is increasing because it is getting filled up from the pulmonary vein. And when it diastole starts, it pushes blood into the left ventricle. So the E wave is the early diastolic wave. When the mitral valve, now here you see, this is mitral valve opens in diastole. And as soon as diastole occurs, the first wave is the diastolic wave, the early diastolic wave. Then when the LV is being filled up from the left atrium, the LV pressure increases and LA pressure decreases because it is now being filled up also. So it tends to close. This is known as an ear slope. In every echo, whether it is a Doppler or whether it is an echo, the A wave is the atrial contraction wave, you see. It comes with it. This is known as an atrial kick. Because the later part of diastole, when the atrium contracts, it increases the cardiac output by almost 20-25%, and CD is the closure point. See, you see, this is the closure point. So when the mitral valve opens because of an increased pressure in LA, this is the first wave, which is known as an E wave. E wave. Then when it tends to partly close because of the equalization of pressure of the LV-LA, it tends to close, and the later part of diastole, the left atrium contracts vigorously to increase the cardiac output. So that is known as an A wave, and this is the closure wave is the CD. That is why whenever there is an atrial fibrillation, there is no A wave and the cardiac output decreases. So these are the normal ways which you will see even in your hands-on training. And unless you see this, you will go on revising and then you'll get what is this also. Now, same thing you see. You see this is the left ventricle. Now, this is the LV, you see this is the QRS wave. Now, you see here, this is diastole. The diastole starts from the end of the T wave, you see here. End of the T wave to the QRS complex is diastole. Then you see there is a systole, and then you see there is a systole going down. In diastole, the heart size increases. It is about 4.4 centimeter because heart is being filled up. So the size increases, and here because it has ejected the blood in systole, the heart size decreases. So this is again another example of a diastole and systole. Again, diastole starts with the end of the T wave and goes up to the QRS complex, and this is the maximum you see going. And from the QRS complex to the next T wave is systole. In systole, the heart contracts, so it becomes smaller. So this is like a balloon which is being filled up in diastole. And they see the removing the air or the whatever balloon that is systole. So I hope I'm going very slow and it is very clear to you. Now this is the only slide of physics we don't want to bring. You must have heard hertz. Sound travels in frequencies. One unit of frequency is that is 1 hertz. So here you see it is 10 cycles per second. So it is known as a 10 hertz. So when you hear that this transducer is a million hertz, so that millions of cycles are there at this. So ultrasound is a sound wave with more than 20,000 cycles or 20,000 hertz per second. Hence, it is not audible to human ear. So this is the only slide of the echo. Now, coming to this Doppler again. So So you have seen all this was up to anatomic information coming to the Doppler. Now, there are three basic requirements of a Doppler. Remember, and I always give this standard example. If you are standing at a railway platform and a whistling train is coming towards you, the engine is the sound source. When the train is coming towards you and the engine gives the sound, it is of a higher pitch because it is coming towards you. As soon as the train passes off, the same sound becomes less. You are experiencing a Doppler every day in your life, but you are not appreciating it. Suppose you are sitting, a mosquito comes near your ear. As the mosquito comes towards your ear, you hear a buzzing sound. Then you just do like this, the mosquito goes away and the sound becomes less. Then there should be a receiver. A receiver is a human ear. They must be moving in relation to one another. If you are standing on a railway platform, the train is also standing, not moving. When the engine gives a whistle, it is of the same intensity, neither less or more, because both of you are standing. And so that, but once it is moving, then there's the sound breaker. So these are the three basic requirements of a Doppler. In echocardiography, the sound source is a transducer. That means it emits a number of cycles or hertz or ultrasonic wave. The target are the multiple of the blood cells which are circulating in the body. So this is the, instead of train, this is the transducer, and instead of human ear is this, and they must be moving towards each other or so. So if there has to be some movement between the two. When this I'll explain to you. Positive is when they are moving toward the transducer, negative away. This you will not understand till I tell you. So remember, transducer is the source, receiver is blood cells, and this is magnitude is depending upon this. Now you see, this hemodynamics is the backbone of cardiology, remember. And Doppler is based technique is mainly it records velocities and the hemodynamics. So that it is the backbone of cardiology, Doppler, hemodynamics, and that hemodynamics is a Doppler-based technique. So what does the Doppler record? It is either the blood always travels. Anything which travels has got some velocity. If you are standing somewhere, there is no velocity. If you are moving, there is a velocity. A train is moving, it has got certain velocity. Anything which moves has got a certain velocity, which is either given as a meters per second or a centimeters per second. So every velocity has to have some basic or so, and Doppler gives you the velocity and the direction of the flow. And this is responsible for hemodynamics. How? I clear to remember one thing, anything which moves in this world has got a certain velocity. A stationary thing has got no velocity. So the velocity can be here or here. Or direction, remember, principle of the direction of the flow. This is important. Go on thinking and reading and then come to us. Now see. This is a parasternal long axis view. This is the aortic wall, aorta, LA. In every view, the LA is behind the aorta, RV, septum, left ventricle, and this. And this is the posterior wall or so. Now, whichever view you take, the transducer is pointing from above downwards. Remember, that is the basic theme of Doppler, very important. Whichever view you take, the Doppler is pointing from above downwards like this. Similarly, you take this. This is short axis view. This is the right atrium, tricuspid wall, RVOT, pulmonary wall, left atrium. As I told you, left atrium is always behind the aorta. So now again, the transducer is pointing above downward. I'm trying to bring this to show this importance that the transducer is always pointing above downwards in every view. Now this is an apical view, remember. the transducer is always pointing above downwards. Now I keep my LV on this side, so this is on this side, but whether it is on this side or this side, apex is always downwards. Subcostal view, you see the RA, RV, interatrial septum, LA, LV, transducer is always pointing above downwards. Now, ये अपने दिमाग में घुसा लो that transducer is always pointing from above downwards. Now you see the direction of the flow. Now you see, this is from the pulmonary vein, the blood goes into the LA. From the LA, it will go into the LV. Because the transducer is pointing downward, so the blood is going towards the transducer direction. Any flow which goes toward the transducer is above the baseline, known as the positive Doppler shift. Remember, transducer is above downwards, blood is going from LA to LV, going toward the transducer. So you see here, this is the mitral Doppler. Because you see the blood is going from LA to LV towards the transducer is above the baseline. So this is the positive Doppler shift. It is above the baseline. Why? Because it is going towards the transducer. Now this is a three-chamber view, you see. Transducer is, now every chamber has to fill up and has to empty itself. Otherwise, there will be no diastole and systole if there is no filling up or empty. Now the blood which goes from the LA to the LV will now go out toward the aorta into the body. As you have seen the first diagram, LV is connected to the aorta for circulation in the body. So when the blood is going toward the aorta, it is going against the base transducer. Transducer is pointing from above downwards, and the blood is going like this and coming out into the aorta, which is against the direction of the transducer, and this is shown below the baseline, you see. Because the blood is going away from the transducer, remember, go on remembering this, the blood towards the transducer is above the baseline, blood away from the transducer is below the baseline. Here the blood from LA to LV through the mitral wall goes toward the transducer, which is pointing above downward, so it's above the baseline, and because it is going away from the transducer, it is below the baseline. Remember this thing. Now you see, again, if you take a tricuspid Doppler, because it is going towards the transducer, it will be above the baseline. But if you take the pulmonary, the blood goes also from RA, RV, from RV to pulmonary artery, because it has to go. Again, the first diagram of RV emptying into the pulmonary artery, you see here it is below the baseline because it is going above this. So I think should be, once you remember the first diagram given and the direction of the transducer and the flow towards and away, we can always find out which is towards and which is away. Now, these are going to this. Remember, this tells you the time. This is the time. What is the time? Systole, diastole, and all this. And this above the baseline gives you the velocity. And shift is above positive Doppler shift or negative Doppler shift. So because this is an aortic wall, so we will forget about it. So horizontal line tells you the seconds, and this tells you the velocity. How much is the velocity? We have measured the velocity here, and again whether it is positive or a negative Doppler shift. Now, again, either you are understanding everything or not, so there is no question. The whole Doppler result depends upon how parallel you are to the flow. Let me fill up my water now. Any flow, we have to be as parallel to the flow. We do not allow more than 10% of velocity. The whole Doppler result depends upon this, how parallel you are to the flow. In 2D echo, you have to be perpendicular, but I'll not confuse you. But in a Doppler, you have to go into how parallel you are to the flow. On that basis, there are three main Doppler modalities: pulse wave, continuous wave, and a color flow mapping. These are the three main modalities which will be demonstrated to you. Now, I won't confuse you with this. Here you see there is a cut. This cut is known as a sample volume. This is a specific feature of a pulse Doppler. Here there is no cut. So there is the whole of the Doppler beam is a CW Doppler. So this is a sort of a sample volume which will tell you just now. And this is no cut is in the CW. Implication is that in a pulse Doppler, it always records a low velocity flow. A continuous wave records all high velocity disease flows. As I showed you this sample volume, wherever you want to study, you put the sample volume. If you put the sample volume on mitral wall, you get only mitral velocity. If you put it on the pulmonary wall, you get only pulmonary velocity. So that wherever you put the sample volume, you get the velocities. So it measured the flow velocity at a very specific site. And here, because they are a high velocity flow and this is a low velocity, there is no sample volume. Now, regarding this thing, all it will be shown to you. Now remember, this is the normal, this you see the cut. This is the cut is the, you see, this is the sample volume. And you see, we have put the sample volume at the tip of the leaflet, so we are getting only the mitral Doppler, which is above the baseline because it's going towards it. In a CW Doppler, there is no sample volume. You see here, there is no sample volume now. You appreciate this. There are two separate lines with a cut in between, but here you see there is nothing like it. So there is no sample volume, and it records a high velocity flows. Now this will be shown to you. Now here you see this is a mitral. We have purposely put a pulse Doppler. You see on a pulse Doppler we have put, and this is the mitral regurgitation because it is high velocity flow. We are seeing both above and below, but will not confuse you. So this will be demonstrated to you wherever I write to be demonstrated. When Dr. Gupta takes you a demonstration, he will show you what is a aliasing when it is above and below the baseline, and because it is a low velocity flow pulse Doppler takes, so we put a CW Doppler which records high velocity flows, and you see it disappears. So remember, I'm not putting a time on it because you see it is now here you see the flow. The flow is 5.7 meters per second. So it is always in meters or centimeters. We normally take meters also. Otherwise, if you take, it is 100 centimeters per meter. So this will be explained to you, don't worry. Now, aliasing can be physiological and pathological. By physiological, I mean, that suppose you have done a resting echo. Now, you ask the patient to climb about 20 stairs. His velocity will increase. That is a physiological aliasing. Pathological is because of any disease state. This will be also demonstrated to you. Forget about it for the time being. Again, this will be demonstrated. Shifting of the baseline, increasing velocity scale, and shift to CW. So remember, because if I tell you now, you will not understand it, but it will be when you demonstrate it, it is always there. For example, if I tell you that this is a normal line, above is 1 meter, below is 1 meter. If I shift the baseline above, the velocity here will increase. Now you see, I have shifted the baseline above, here the velocity has increased. And vice versa, this will be, now here you see, it will be vice versa. So I think this will be demonstrated. Now the main pulse Doppler at this stage of you, it records flow across the normal walls. When we come to stroke volume, we come to diastolic, will be another thing. Remember, a pulse Doppler will record from a very specific site, and it records the loss across the normal walls and vessels, while a CW Doppler records all high velocity flows across various, all disease flows are high velocity flows, stenosis, regurgitation, prosthetic valve, PA pressure, all these are high velocity flows. All disease flows are usually high velocity flows, so they are taken by continuous wave Doppler, while a pulse Doppler records a normal flow. Now, why the velocities are converted into gradient? What is the gradient? A gradient is the difference of pressure between the two chambers. A flow from a high pressure flows to a low pressure chamber. So the difference of pressure between the two chambers is known as the gradient. And according to this Bernoulli equation, pressure gradient is equal to 4 into velocity square. Suppose you have taken a velocity of 4 meters per second, the gradient is 4 into velocity square 64. So that is why, remember, if you take a wrong velocity, your result will be wrong. So that is why no hurry, take all possible views and try to get the maximum velocity. Suppose here you would have taken a 3 meter per second, so this will have come to 36. This will have underestimated your severity. So remember this, all velocities which you take from a Doppler are automatically converted. You don't have to do anything, are automatically converted into gradients. For example, here you see, here the velocity of a TR jet, now the TR is going away from the baseline, so it is below, away from the transducer. Now we have recorded a velocity of 5.4. This automatically tells us that the gradient is 122. You take 5.5 into 5.5 into 4, come to 120, 122. So our job is to take the best possible velocity, and the machine automatically will give you a gradient. You don't have to do anything. Now, again you see, we have taken this velocity also. Now, we have taken a peak velocity of 4.72. It has already given us a maximum 4 into velocity square. So our job is to take the best possible velocity, and machine does everything for you. Now there are three gradients. Don't get confused, they are very simple. One is peak. Peak is 4 into velocity square. Now, it is related. Now, suppose I give you one example. Suppose you have taken an aortic velocity of 1 meter per second. Now, suppose you develop an anemia, thyrotoxicosis, this 1 will become 2. Or you climb 20 stairs, it will increase because you have done this thing. So this is related to the blood flow. Mean is an average of multiple instantaneous gradients. That is more reliable. With geopolitics, I'll give an example. Suppose a lady has to look after a groom or a fiancé. If she sees only one man, she has no choice. If she sees 5%, she has more choice. So a mean is an average of multiple gradients. Hence, it is more reliable rather than one single measurement. So, and how to do it also will tell you. Then you'll always hear a word, velocity time integral. It is the distance in centimeter the blood travel is 1 stroke. Now, suppose your heart is functioning well and the heart contracts, it may push to about 22 centimeters or so. If the heart function is getting poorer, it may come to about 18 or so. So it is an indirect evidence of giving a stroke volume on the cardiac output. And how do we get it? You remember, peak is a single value. Mean is an average of multiple gradients. Now see, again you see this is what we known as the modal velocity, because the peak one, the more thicker one, a prominent by the modal velocity, very measure also. Now see, this is systole. From the QRS to the T wave, and the Doppler here plays a mitral valve, it takes a velocity, it automatically tells us the gradient, what is the gradient or so. So now this is known as a peak velocity. This is known as the peak velocity, and this is the peak gradient. I told you that This is the 4 into velocity square. So you take a velocity and it 4 into it tells you the beam. Now in mean, what happens? We always trace, whenever you trace the envelope, you get peak velocity, mean velocity is VTI. So that if somebody asks you, how do you want to calculate a VTI, you say that we'll trace the Doppler envelope. Now there you got only peak. Now you see, being a Michael valve, low velocity flow, we have put a pulse Doppler. So the basic thing to tell you is to obtain a mean gradient and VTI, just trace the Doppler envelope and machine automatically give you all the results also. Now so you see, this is the aortic wall below the baseline. We have traced the Doppler envelope. We automatically get peak velocity, mean velocity, peak gradient, mean gradient, and a VTI. So that in many diseases, the mean are more important than peak. So that remember one thing, always will make you practice it. Whenever you planimeter it, it gives you all the velocity. If you only measure the peak, it will give you the peak velocity. And you see, it automatically gives you the VTI also. So the VTI is VTI is only the distance in travels in one stroke. It has got a lot of value in emergency medicine, which will be told to you later on. So that remember, a simple question asks that what information you get from tracing a Doppler envelope, peak velocity and gradient, mean velocity and gradient, velocity time integral, all this we have been explained to you just now. Again, the same thing I've been told you just now. Now coming to the last part of the color flow mapping, it is a major breakthrough. You can see the blood. Now, as I told you, you have to be as parallel to the flow as possible to get the best Doppler. So when you see the blood flow, you can automatically put your Doppler according to the flow and you'll be completely parallel to the flow. So that means it is a very important parameter. According to the universal convention, flow towards the transducer is red, flow away from the transducer is blue. Now coming to the same thing, remember your transducer is pointing above downwards. This is left atrium, this is the left ventricle, this is aorta. The blood which is going towards the transducer is of a red color, and the blood going away from the transducer is the blue color. Again, remember, always the direction of the transducer you are working, it is the same. So you can red going there, blue going here. Now you see here, when you do, you keep LV on this side, you see this is the LA. I put the LV this side now. Now LA, LV. Now it is going towards the transducer, hence it is of a red color. And you see, it is going away from the transducer, so it will be of a blue color. You see, blue color. So just remember direction of the transducer, flow towards and flow here. And it is such a sensitive technique that just two tiny traces of air can be picked up. This is the aortic wall. And from aortic wall, the blood is coming, which is going red means towards the transducer. And the only thing which goes in diastole is the aortic regurgitation. Just forget about it also. Now, remember another important thing. All red flows, the Doppler is above the baseline. Why? It is a very simple thing which you will remember if you revise the chapter by today. All red flows mean that going towards the transducer. And as I told you, Doppler, any flowing going towards the transducer is of above the baseline. So they go simultaneously together. All blue flows, the Doppler is below the baseline because it is going away from the transducer. So the basic thing, flow towards the transducer, red and above the baseline, flow below the all above from the transducer, blue and below the baseline. Now you see, this is the pulmonary wall. This is the right atrium, RV, pulmonary wall. You see a blue flow. So the blue flow is coming because it is going away from the transducer. The away from the transducer means it is a blue flow. So because it is a blue flow, the Doppler will be below the baseline, you see. The Doppler is below the baseline because it is going away from this. Again, you see this is mitral regurgitation. It is going away from the transducer. So this is below the baseline. You see, the the blue flow, this is transducer coming from this side. And when you are told the word valvular regurgitation, you'll understand it better. The blue flow away from the transducer is usually a mitral regurgitation. And because it's away from the transducer, this is also a negative. So they go together. Now you see, this was a patient of aortic stenosis regurgitation. See, stenosis going below, regurgitation going above. Now you see, this is the tricuspid wall. Flow will go from RA to LA, RA to RV, which will be going towards the transducer. So it will be of a red color. You see, it will have a red color, and because it's going towards the transducer, this is a positive Doppler shift. So the positive Doppler shift with the red color, a negative Doppler shift with the blue color. That will be, and so when there is a all disease flows have got a mixture of color. For example, here you see it is straightforward single color, simple color, straightforward simple color, no flow exactly also. But here you see, again you see what I told you, this is the flow going from LA to LV, and again this. Now this is of a uniform color, but when it is a disease flow, it's a mixture of color. Now you see, the color has changed. Now this tells us that there is a flow from the mitral wall toward the transducer. Outside is blue, multiple color, and the blue color is mitral regurgitation. So all this turbulent flow. So I now suppose this is the severe mitral regurgitation. Importance is that suppose to hear a systolic murmur. Now systolic murmur, just common example, systolic murmur can be because of pulmonary stenosis, can be VST, can be MR. So you put the color on the pulmonary wall. If there is no turbulence, pulmonary stenosis is ruled out. You put it on the septum, nothing ruled out. So that means that just where you put the turbulence start, that is the state for it. Again, you see this is normal flow. And you see a turbulent flow. This is the aortic wall. This is the going away, and this is the going other. So this is aortic stenosis. This immediately tells you that this is the diseased area. So you'll get it more with your experience also. Now here you see two flows coming, LV, RV, TR, and you can see. So there's no other way you can do it. It is only the TR which tells you. And when we tell you pulmonary hypertension, importance of this. So this color gives you a telegraphic comfort. So the difference between 2D echo and a Doppler is, in 2D echo you see the tissues, in Doppler you see the blood. In the 2D echo you see the anatomy of the structures. Here you see the physiology. In information is structural. So how much is the size of the chamber, how much is the thickness of the wall, how much is this. Here you get a hemodynamics, alignment, perpendicular, that is why you get a best personal log axis view. Here completely parallel and quantitation semi, and this is accurate. Now, so again remember, tips use pulse Doppler in situation of normal flows. If aliasing occurs, revert to CW Doppler. Use CW Doppler in all disease stages where high body is expected. And when you place that, always place the sample volume at the tips of the leaflets, not anywhere else. So, so remember, this is a basic pulse which will come to know two basic dictums. In which view I am is this wall seen? Am I parallel to the flow? Remember, these are the two basic dictums of a Doppler. In which view or the views I see this wall seen? Am I parallel to the flow? Pulse Doppler sample volume, use multiple planes, try to obtain maximum velocity by the other things also. So this will be demonstrated to you how to get a good color flow, and there's no point in theory telling it. Again, this will be told to you. The various control panels will be easy for you when you see online. So again, I told you, important take-home message. In which view this wall is seen? Am I parallel to the flow? For example, you see here, this transducer is pointing above downwards. So the mitral valve is not parallel to it, is perpendicular to it. So you can't take any mitral or a Doppler in it, aortic. Same patient. Now this is a different patient. You see, LALV, and the blood is going towards the transducer. So here you can, apical view, you can take the mitral Doppler because you are parallel. Again, you see, here again you are seeing parallel to the flow because transducer pointing outward, you can be parallel to the flow. Same aortic wall. So again you can, now you see again you see, now see anywhere you see this going, you see this all for the tricuspid wall, you see various views here, forget about it. Again, and the subcortical, these will be told to you subsequently. So, when you are hands-on being done, read. Remember, please read first two lectures well for understanding. Every lecture you are getting, please read something about it. Otherwise, you will be completely lost. Full clarification of pulse Doppler and CW at the hands-on demonstration, either at the Dr. Gupta's level or our level. Clarify aliasing, effect of baseline shift, demonstration of Doppler control panels, and all this. So all then learn how to get way to all many of these things will be told to you during the live demonstration here and also during the hands-on. And these are some of the normal velocities. So the take-home message is Doppler is the backbone of cardiology. It gives the hemodynamic information and records velocities. Pulse Doppler records low velocity flows from specific sites and at the tip of the leaflet. Into the number one, it records low velocity flow from a very specific site, and you put it at the tip of the leaflet. Interrogate every wall. CW records all high velocity and disease flows. In cases of aliasing or turbulence, do a CW Doppler shown to you. Peak gradients are 4 into velocity square. Mean gradients and VTI by planimetry. For practice, calculate gradients in every case. When you come on hands-on, you'll have to practice in every case. For good Doppler envelope, all these will be shown to you. There's nothing short of a be parallel to the blood flow with the help of a color flow mapping. This is not for publicity. I never do my publicity. But in case you need any clarification, any slide or anything, you can contact us or Dr. Gupta, anybody. These are this and this is the other thing also. These are not your thing. Any question till now? I have tried to be as slow as possible. Please read it. Please read it. Nothing short of. You have to take a full advantage of the course. Otherwise, there is no purpose of coming here. You'll appreciate that all this will be more important when you have read it. The anatomy diagram which I showed you, you must remember daily. Always practice diastole, systole, make clarification, and then ask us if need be. If there's so please either you when you read it, you can ask for a clarification later on, or any doubt during the hands-on training now or during our time, please do it also. Any lecture in future, please read the first two chapters carefully so you can understand. So Reena is there.
Sir.
If there is no question, then can we?
Sir, few questions are in chat box. So anybody
I
has
don't.
question to Dr. Parashar, sir,
No,
kindly raise your hands.
I don't want chat box. I want questions to be put
Yes.
immediately while they are going on.
Sir,
Otherwise, now
someone asked for explain the aliasing.
I,
Dr. Ruchi
I
Sharan asked for explain the aliasing.
that means he was sleeping when I told him. I told you that aliasing will be told to you at the hands-on, because that will not be easy for you to understand. That is when I told you that I may explain anything, but it will not be clear to you at that time. So that is what it will be shown to you. So I think you were not clear at that time, neither you were hearing, you might be sleeping also. So see, aliasing to be demonstrated. You read whatever you want, but it will be demonstrated. Whatever I tell you, you will not understand. I can only tell you one simple thing, that when there is a high velocity flow, go straight to a CW Doppler rather than to a pulse Doppler. So that is the aliasing will be demonstrated in a 2 to 3 days or so. So don't worry about that. Anything else? Say whenever there is a certain velocities which is known as the Nyquist limit. If a beyond certain every machine has got some limit, beyond this aliasing occurs. Suppose a velocity is more than 1.5 to 2 meters per second, the aliasing will be above and below the baseline. So that means you have to remove the aliasing, and that I told you will be better demonstrated. That will be easy for you. I knew what questions will come, so I always marked in red that they will be demonstrated to you. Or
Sir,
कुछ
we'll be demonstrating live to them, sir.
ऐसा है कि Dr. Gupta will be demonstrating to you live in shortly, and then it will be demonstrated in the hands-on also. So Reena,
Sir.
are these hands-on, are these demonstrations being done in between or not?
Yes, sir. Sir, most likely next to next class will be
So
the.
that means this will be demonstrated to you. Don't worry. Before you come to the hands-on, this will be demonstrated to you.
Sir, everything will demonstrate live most probably next to next class, sir.
Yeah, but that doesn't mean that you stop reading.
No, they should read, sir, definitely. And
So make it a habit now. Believe me, the whole course will go waste if you do not read at least 30 to 40 minutes a day. So this will always be now. Only few now. I think by now you should be knowing what is a positive Doppler shape, what is a negative Doppler shape, why the color is red, why the color is blue, why the Doppler is below. I mean, that it cannot be then, but this will sometime be demonstrated also. So whatever you want clarification, keep the points with you, and then it will be told to you. Yeah.
and we'll be sending books very shortly to all of them. Hopefully by next class they'll be receiving all
Hello.
of them. Sir. We'll be sending the books also to all
अभी
of them.
लेक्चर हो रहा है, अभी रिंग करते हैं. हाँ. What else?
Any other questions by anybody? So thank you very much, sir, for all your elaborate description of Doppler and colorful mapping. I hope they learn with this over a period of time. That's what we are looking forward, sir.
Thank you, thank you, thank you.
Thank you, sir. Thank you, everybody. Enjoy your dinner. And next week, we'll meet at 9 o'clock in the evening at usual times on Wednesday. Thank you very much, everybody.